Welcome to this explainer. You know, we usually think of our immune system as our ultimate shield, right? Our internal safeguard against infection. But what happens when that shield literally turns into a weapon? Today, we're investigating a fascinating and honestly pretty aggressive microscopic rebellion. We're going to describe anti-neutrophil cytoplasmic antibodies, or ANCAs, and really dig into their uses in medicine and how we interpret them when the body's defense network gets completely rewired. We're pulling our clues for this investigation directly from the immunology section of the GM26 Basic Science Ready Reckoner. It's this fantastic, highly condensed medical resource, and we're zeroing in on Chapter 9 to crack the case of a very specific, very destructive cellular mix-up. So to really wrap our heads around this, imagine the immune system as an elite police force. Within that force, your neutrophils, well, they're the beat cops. They are our fast-acting first responders. But suddenly, a hacked communication turns these very defenders against the body's own infrastructure. They stop fighting the bad guys and literally start attacking the city they're sworn to protect. That hacked signal and the massive damage it causes, that is the rogue mystery we're solving today. Here's our roadmap to break it all down. We'll meet the ANCA antibodies, look at how ANCAs attack vessels, compare C ANCA versus P ANCA, spot ANCA vasculitis, go over testing and interpretation, and finally, look at treatment and monitoring. All right, part 1. Let's meet the ANCA antibodies, our primary suspects.
The absolute crucial point here is what ANCA actually stands for, anti-neutrophil cytoplasmic antibodies. Now, in a healthy body, antibodies target foreign invaders, like bacteria. But autoantibodies, they mistakenly target our own cells. In this specific case, they target the cytoplasmic granules located right inside our own neutrophils. Because of this massive biological mix-up, these antibodies are the prime indicator for a group of really dangerous conditions we collectively call small vessel vasculitis. In modern medicine, identifying this specific biomarker is incredibly important, simply because it saves critical diagnostic time when a patient's vessels are under attack.
Moving on to part 2, how ANCAs attack vessels. Let's check out the scene of the crime. So the pathogenesis, or the actual mechanism of the disease, unfolds in 3 really clear steps. First off, the ANCA autoantibodies bind to primed neutrophils that are just circulating in the blood. This abnormal binding is the main trigger. Step 2, the confused neutrophils degranulate. They basically unleash their chemical weapons, things like highly reactive oxygen species and destructive proteolytic enzymes, right into the bloodstream where they absolutely shouldn't be. And then, step 3, this toxic release directly damages the endothelium. That's the delicate inner lining of our small blood vessels. The first responders are essentially burning down the streets they're supposed to be patrolling. Part 3, CANCA versus PANCA, the 2 main variations. Now, when it comes to medical interpretation, distinguishing between these 2 variations is absolutely vital for an accurate diagnosis. First up, we have C ANCA. If you look under a microscope, this one shows a diffuse granular pattern all throughout the cytoplasm, and it specifically targets an antigen called proteinase 3, or PR3 for short. Clinically speaking, finding this usually points us toward granulomatosis with polyangiitis, or GPA. Then on the flip side, we have P ANCA. This one shows a perinuclear pattern, meaning it clusters tightly right around the nucleus. Its main target is myeloperoxidase, or MPO, and it's most commonly associated with microscopic polyangiitis and eosinophilic granulomatosis with polyangiitis, also known as EGPA. All right, part 4, spotting ANC vasculitis and its clinical features. When those small blood vessels are under attack, the fallout is systemic, and it's incredibly severe. Since small vessels are quite literally everywhere in your body, the symptoms can pop up all over the place. We frequently see patients developing posse-immune, rapidly progressive glomerulonephritis, and that is a very fast, very dangerous failure of the kidney's filtering system. We also see pulmonary hemorrhage, that's active bleeding into the lungs. Patients might also present with severe, unrelenting sinusitis, or mononeuritis multiplex, where multiple individual nerves are damaged. That causes deep pain and weakness. It really is a terrifying cascade of symptoms. By contrasting these specific conditions side by side, we can easily spot the unique clinical clues that medical detectives use to separate them. For instance, with GPA, doctors are going to look for the formation of granulomas in the upper respiratory tract. Over time, this can actually lead to the destruction of nasal cartilage, resulting in a classic saddle nose deformity. Compare that to eGPA, where the standout clues are a clinical history of asthma, combined with marked eosinophilia. That's an unusually high count of a specific type of white blood cell in the blood. These very specific clues help pinpoint exactly which flavor of vasculitis we're actually dealing with. Moving to part 5, testing and interpretation. How we actually catch these antibodies.
Detection in medicine requires a rigorous two-step verification process to ensure we're interpreting things accurately. Step 1 relies on indirect immunofluorescence. This is where laboratory technicians use a fluorescent dye to physically see if the glow under the microscope is that cytoplasmic C ANCA pattern or the perinuclear P ANCA pattern. But, a visual pattern just isn't enough to convict, so step 2 uses a highly sensitive test called an ELISA to confirm the exact molecular antigen. Is it definitively PR3 or is it MPO? This strict interpretation workflow moves us from a visual suspicion to absolute biochemical certainty, which is a real game changer for modern diagnosis.
However, despite all of this high-tech blood work, we always have to remember this golden rule, straight from our source material. Tissue biopsy remains the gold standard for confirming vasculitis. ANCA supports, but does not replace histology. Basically, the blood tests are fantastic circumstantial evidence that heavily support the case. But getting a small sample of the affected tissue, like, say, a tiny piece of the kidney, and seeing the actual inflammatory damage directly under a microscope, that is still the only way to reach a final, undeniable verdict.
And finally, part 6, treatment and ongoing monitoring. How do we stop the attack?
So those blood tests we just talked about, well, they aren't just for that initial diagnosis. Doctors use the ANCA titers, which is the actual concentration or level of these autoantibodies in the blood, to monitor the disease's activity over time. In medicine, interpreting these ANCA titers acts like an early warning radar for a relapse. If a patient is doing well, but their ANCA titers suddenly start creeping back up, it allows doctors to proactively adjust therapy and intervene way before the blood vessels take another massive hit.
And what does that therapy actually look like? Well, to stop an immune system that is actively attacking itself, you literally have to aggressively suppress it. Treatment relies on heavy-hitting immunosuppressant drugs. We're talking about high-dose steroids to rapidly bring down the inflammation, alongside targeted therapies like rituximab, which depletes certain immune cells, and cyclophosphamide. These are serious, potent medications. They're specifically designed to quiet down that rogue immune response and forcefully prevent any further irreversible destruction to the patient's vital organs.
It really is a fascinating, if maybe a little terrifying, biological mechanism. If autoantibodies like ANCs can so completely hijack our immune system and turn our trusted first responders into wrecking balls, it leaves you wondering, what other rogue signals are hiding in our biology, just waiting to be discovered as we continue to map the incredibly complex mysteries of the human immune system? Thank you so much for joining me on this explainer. I really hope this helped clear up the mystery of ANCA vasculitis, how we describe it and how we interpret it in medicine. Keep learning and always keep questioning.